as well as RML Hospital, New Delhi, and is a senior resident from 2015 to 2018 in New Delhi Hospital, and Divisional Medical Officer 2019 to 20 in Southern Railway, and Faculty of Medicine Department of JIPMER from 2020 onwards. Critical care, and he published about 15 articles. I welcome you, sir.
And I wish you a very happy New Year to everybody. And at the outset, I thank the API Tamil Nadu chapter and the organizing team of MIDTAPICON 2025 and Dr. Ravichandran for giving me this wonderful opportunity. I am going to talk about acute on chronic liver failure for 20 years, and diagnosed to have cirrhosis of liver 2 years back. And he has a past history of hospitalization for ascites and hepatic encephalopathy 6 months ago, which resolved after treatment. Now he presented with fever, jaundice and ascites for 2 weeks. Along with that, he has worsening of sensorium and decreased urine output for 3 days. On examination, he had very deep icterus, and grade 3 hepatic encephalopathy was there, and he had hypotension. On investigation, there was a hyperbilirubinemia, transaminitis, and there was a coagulopathy, and his creatinine level was elevated, and ascitic fluid analysis is suggestive of spontaneous bacterial peritonitis. Does this patient have acute on chronic liver failure or not? We will get the answer after some time. So, acute on chronic liver failure is a recently defined definition. It's nothing but an acute deterioration of chronic liver disease with a high short-term mortality. It is different from both acute liver failure and acute decompensation. In acute liver failure, the underlying liver will be completely normal. But in acute decompensation, the short-term mortality will not be very high. As we are seeing in this table, there is a significant high short-term mortality for both 28-day and 90-day. ACLF patients are having very significantly high mortality compared to acute decompensated patient without ACLF. And coming to the definition, there is no universally acceptable definition for acute on chronic liver failure. There are 3 prominent definitions available in the literature. One is Asian, second is European, and the third is American. Among these 3, the most commonly used definition for research purposes are European definition. European definition is defined by European Association of Study of Liver. According to this definition, ACLF is a syndrome characterized by acute decompensation of cirrhosis associated with hepatic or extrahepatic organ failure with high short-term mortality. What's the pathophysiology behind ACLF? Inflammation is the cornerstone of pathophysiology of acute on chronic liver failure. How this inflammation occurs in ACLF? There are 2 pathways. One is through the damaged necrotic cells from the injured liver releases damage-associated molecular pattern. Second is if there is a bacterial infection or translocation of bacterial products from intestinal lumen, there will be a release of pathogen-associated molecular pattern. These both pathways in turn activates the pattern recognizing receptors in the innate myeloid cells, which further increases a systemic inflammatory response through which there is a release of cytokines and inflammatory mediators. These cytokines and inflammatory mediators through 3 different pathways further leads to intense vasoconstriction, which causes tissue hypoperfusion and mitochondrial dysfunction and immune-mediated tissue injury. Ultimately, this pathophysiology leads to multiple organ failures. So this is what happens in ACLF. A precipitating event attacks the cirrhotic liver, then there will be an excessive systemic inflammation. Further, there will be a development of acute decompensation along with organ failure. The combination of this acute decompensation with organ failure is considered as acute on chronic liver failure. So what is acute decompensation? In a known cirrhotic patient, if there is a development of ascites, hepatic encephalopathy and variceal bleed, we will call this as acute decompensation. What are the precipitating events? There are 2 types of precipitating events. One is hepatic, another is extrahepatic. Hepatic precipitating events are directly related to the liver. Those are alcohol-related hepatitis, circulation and lung. For each these 6 organs, 6 parameters are taken into consideration. For liver, bilirubin is taken. For kidney, creatinine. For brain, hepatic encephalopathy grading as per West Haven's criteria. For coagulation, INR is considered. For circulation, kidney failure, that is creatinine more than or equal to 2, or cerebral failure with creatinine as 1.5 to 1.9, and any organ failure among these 4 mentioned with creatinine of 1.5 to 1.9 with or without hepatic encaph of grade 1 or 2. So this is the criteria for ACLF grading. And the European definition also has given a predictive scoring system for short-term mortality. The scoring system is called Chronic Liver Failure Consortium Acute on Chronic Liver Failure. So for calculating this score, we need 3 parameters. One is Chronic Liver Failure Consortium Organ Failure Score, which we have seen in the previous slide, and age and WBC count. The studies are showing that this CLIFC ACLF score predicts the short-term mortality better than the available scores like MELD, NA and CTP scores. And in this slide, I have shown the difference between the Asian criteria and European criteria. In Asian criteria, is very stringent criteria. It considers only compensated cirrhosis or non-cirrhotic chronic liver disease. It does not include the decompensated liver disease. But in European definition, it includes a decompensated cirrhosis also. And in Asian definition, only the first episode of deterioration is considered for definition. But in EASL, it includes the prior decompensation as well. For Asian definition, only the direct hepatic injury is considered as a precipitating event. But in European definition, both hepatic and extrahepatic precipitant events are considered for definition. For Asian definition, only the bilirubin, INR and hepatic encephalopathy is considered for organ failure. But in EASL, along with these 3 mentioned organ functions, also the kidney, circulation and respiratory function also taken into account. So coming back to our case scenario. In our case, the patient is having underlying cirrhosis and having a prior decompensation, and also the precipitating event we consider here is a spontaneous bacterial peritonitis, which is the extrahepatic precipitating event. So according to EA, so coming to the management of ACLF, since the patient may have organ failures, they may require admission into the ICU or HTU. And there is no specific treatment for acute on chronic liver failure. We have to give the supportive therapy to the organ failures. So if we suspect infection, we should start the broad spectrum antibiotics early, because systemic inflammation is the very important thing, and the most common precipitating event noticed in ACLF is infection. And if the patient is having kidney injury and the criteria fits into the definition of HRS, we should consider giving albumin with terlipressin or noradrenaline. And if the patient has very severe kidney injury, we should consider giving renal replacement therapy. If the patient has bleeding due to coagulopathy, FFP transfusion should be considered. For hepatic encephalopathy, lactulose and gut antibiotics needs to be given, and sedatives should be avoided. In shock, fluids initially, later inotrope support. If there is a refractory shock, we can give hydrocortisone. If the patient develops respiratory failure, we have to intubate and give the ventilatory support. And next to the organ failure support, we should treat the precipitating events. If there is a HBV virus flare, we should give the antiviral agents. And if we suspect autoimmune hepatitis or alcohol hepatitis flare, the role of steroid is controversial. If we give the steroids for this flare, we should closely monitor the patients for the development of infection. If the patient has varicose bleed and the facility is available, we should go for the procedure tips. And the newer therapies like extracorporeal liver support like albumin dialysis, plasma exchange and colony stimulating factor granulocyte therapy, this and all having inconsistent short-term mortality benefit in the studies. If we need a long-term mortality benefit, we should consider liver transplantation. Coming to the prognosis, if the patient is having 4 or more organ failure, or the CLIFC ACLF score is more than 70, and if there is no option available for liver transplantation, those patients are having very poor prognosis. So these are my take-home messages. ACLF is a very challenging clinical event. It starts acutely, progresses rapidly, and it lands up into organ failures, and it associated with high short-term mortality. Because of the geographical differences in the definition and diagnostic criteria, the diagnosis of ACLF is challenging. So there is no specific treatment for ACLF. We have to treat the precipitating event, and we should provide the organ support as per the organ failures noted. So let me conclude my talk with the Tirukural related to this topic from Kallunnamai Adhigaram. Unnarka Kallai, Unil Unga, Sandroran Ennapada Vendadar. One should not consume alcohol. However, if someone does not wish to earn the respect of the wise men, they may drink if they so desire. Thanks for your patient listening.